Okay, this video is going to be called Transient Visual Loss. So this can be transient visual loss in one eye, monocular, like amaurosis fugax. It can be in both eyes. It could also be what we would call cortical blindness, whereby the person can still see, but the ability to interpret what they see is damaged due to a problem in the occipital lobes, the visual cortex, or the parietal lobe, which are a big spot for understanding things like the language interpretation area, Wernicke's area, and all that. So anyways, I'm going to go through what's involved because I get asked this question a lot. I see a lot of patients that come through the emergency room for visual loss. You know, my function is primarily as a neuroradiologist in this context, but I have to know what causes these problems, how to interpret them in order to be able to contribute to diagnosing these patients and treating them. Okay, so the brain has blood supply from 4 arteries, 2 in the front called the carotid arteries, 2 in the back called the vertebral arteries. We usually just call them the verts. And there's a tiny little connector artery in the brain between the carotids and the verts right here. It's called the posterior communicating artery. Actually, the vertebral arteries come up and they join together to make the basilar artery, which is right in the spot of the basilar cistern in front of the brain stem. Okay? When the carotid artery comes up, it'll bifurcate in the anterior and the middle cerebral artery. So anyways, anterior circulation, posterior circulation. Okay, now just showing a little bit more detail about these arteries. This is the carotid artery. The green arrows are drawn in the internal carotid artery. I always remember it as like my thumb. There's no branches of the internal carotid. It goes right up underneath your chin into the brain. All the fingers come off the external carotid, all the branches. Those go to the face. Okay. When the blood flow comes up from the heart, it comes up in the common carotid artery, bounces against the median divider. External carotid artery, ECA, goes to the face. ICA goes up to the brain. Okay, now we run into what you call the Goldilocks situation. So Goldilocks means you get the perfect balance, the golden mean. Not too much, not too little. Okay, so blood comes up the internal carotid artery, goes out to the middle cerebral artery, around the cerebral convexities. Then the penetrating arteries go into the brain parenchyma and supply this area adjacent to the ventricles. The area adjacent to the ventricles where I got the skull and crossbones is called the periventricular. Peri means next to. So the periventricular area. There's actually 3 levels to the brain that we talk about all day long. There's the basal ganglia at the level of third ventricle, this vertical one right here. Then there's the corona radiata at the level of the lateral ventricles, which are paired, one on each side. There's only a third ventricle in the middle. And then centrum semiovale is right above the lateral ventricles. It's because it's in the center and it's semi-oval in shape when you look at it on an axial, transverse section of the brain. Okay, so what's going on is if you have too much high blood pressure, you can stroke right here in the basal ganglia. Those are called lacunar infarcts. Pretty common type of infarct. But if you have too little blood pressure supplying the brain, you can drop the pressure to where the skull and crossbones are. That's by far the most common site of stroke. I see about 1,000 strokes in this area for any stroke anywhere else. Okay, all day long. Overtreated hypertension is a big cause of that. Okay, now here's the most common look I see on a demented brain. I just see a shrunken brain. Normally the brain parenchyma, like let's say you gave me a 30-year-old, the brain would be uptight against the skull. But you keep losing brain cells as you get older, especially if you got bad habits, high-fat diet, smoking cigarettes, drinking alcohol, and the brain just shrinks away. So here would be a normal brain in this coronal section here, and here would be severe atrophy. Okay, and this is the most common thing I see in dementia. I don't see any of those other rare treatable causes. This is what I see, like 95% of the time. All right, so here's Goldilocks, the idea of a balance. Not too much blood flow, like hypertension, severe hypertension. Not too little, like hypotension, underperfusion of the brain. We want to get the golden mean, Aristotle's golden mean, just the right amount. Here's a look at the brain from below. And so here's the vertebral arteries coming up in the back, forming the basilar artery. And then the basilar artery comes up and splits into the posterior cerebrals. Those go to the occipital lobes for vision. These are the carotid arteries that were coming up. They split into the middle cerebral artery around the side of the brain. Anterior cerebral artery goes right down the middle in the front. I'm going to show you on the next image what that looks like on an MRA. MRA means magnetic resonance angiogram. So it's like an MRI, but just of the blood vessels. And this is what's called a submental vertex view, where they're all compressed down upon each other. But you can still make out the general idea that the ICA, internal carotid arteries, come up one on each side, anterior. This is anterior. Whenever you look at a CAT scan, MRI or an ultrasound, it's always as if the patient, you walked into a room and the patient's feet are facing towards you. So this would be the right side, this would be the left side, because their feet are facing towards you. Okay, so middle cerebral artery, MCA, going out around the side of the brain, ACA, anterior cerebral artery, going up, down the middle. Okay, I remember the ACA is like a mohawk haircut. I remember the MCA is like Bozo Circus sticking out on the side. And I remember the PCAs, posterior cerebral arteries here, as being like glasses put on your head backwards because they supply the occipital lobe for vision. Okay, so that's how you can easily remember the territories. Okay, here's a common cause of stroke would be atrial fibrillation. You got poor conduction in your cardiac atria. They're the initial preliminary loading chamber before they push the blood into the ventricles. And a clot can form there if you've got abnormal contraction of the atria because you get stasis of blood in there. Blood always has to keep moving or a clot. Okay, so anyways, you toss the clot up to the brain, and this would be a stroke in the middle cerebral artery due to AFib. Okay, so here's the example case where you've tossed a clot up and it's occluding the right middle cerebral artery. See how the normal the left middle cerebral artery goes out and branches? Here it abruptly ends. All right, so that would be an abrupt large vessel occlusion. This is a CT angiogram of the brain. All right, so this is what this can look like. If this is a really big stroke right here, this will often kill the patient if it's this big. And this is a CT. This is not the same patient where you'd have a completed infarct, big infarct. This patient's going to be hemiplegic on the other side of the body, on the left side of the body. These low density areas in the periventricular regions are, again, a typical thing I see in elderly patients due to multiple small hypoperfusion strokes, what we were talking about with regard to overtreated hypertension or even chronic hypertension itself, untreated with intracranial atherosclerosis, blocking the blood vessels to the periventricular white matter. Okay, white matter just means myelinated fibers, but not cell bodies, not where the nuclei are. Okay, here is DWI imaging of an acute stroke. DWI means diffusion weighted imaging. This is a FLAIR image, which is like a CSF, cerebral spinal fluid suppressed T2 image. On T2, fluid is bright. It takes 6 hours for FLAIR to become positive. So in the acute setting, you know, FLAIR is going to be negative. It's going to be false negative. But DWI is called diffusion weighted imaging, and that will be positive immediately, as fast as you can put the patient on the table. And that's the best way to diagnose acute stroke when you need to know right away of an acute onset stroke. When it becomes low signal on the associated ADC map, that's called diffusion restriction. That means the stroke is less than 6 days old. Okay? If DWI is positive but ADC is not, then it's probably subacute, like 1 to 2 weeks old typically. Okay, so here let's get back to our right middle cerebral artery acute occlusive stroke with a large thrombus occluding the right MCA so you don't see its branching vessels. In this case, you can do a unique procedure called transcatheter thrombolysis. They'll thread a catheter up the internal carotid artery, go all the way out into the right middle cerebral artery of this little retrievable basket, and they can basket out the clot. Now, that's a beautiful thing, good on a Hollywood movie, okay, but it hardly ever happens. You know, about 1 in 1,000 strokes undergoes this procedure. You know, it's a beautiful, wonderful thing when the setting is right and it's done, but it hardly ever is this setting, okay? Maybe less than 1 in 1,000 strokes. It's rare that you get a big acute stroke, clot in here, transcatheter, remove it. It's great when it happens, but that's just not the usual thing. Oh, here you can see the guide wire out up into the MCA ascending convexity branches when they fished out this clot. Okay, here's what a normal brain looks like. Again, it's uptight against the skull. The cerebral ventricles are small. Okay, this would be a FLAIR sequence. CSF signal is suppressed, so you have dark fluid in the ventricles. Hypointense is the MRI word for that. So here's a FLAIR image of an atrophic brain. Like this would be a typical demented brain. All these white spots are small strokes, and they're coalescing together. So this would be coalescent periventricular white matter, chronic ischemic changes, chronic strokes. Okay, these are often relatively asymptomatic or having minor symptomatics initially, but the more of them you get adding up, the more brain is destroyed, the more symptomatic the patient becomes. And you see the abnormal white stuff, that's called hyperintense signal on MRI, but around it there's poor perfusion, meaning that the brain is damaged beyond what we can see, and the area around it is at risk to also become damaged and dead, and so you'll have that white spot grow. Like here, it'll have grown and it's coalescing together. And notice that the ventricles get bigger. As the brain tissue is destroyed, the ventricles expand into the destroyed space. That's called ex vacuo dilation of the ventricles. And you can see there's hardly any cerebral spinal fluid along the periphery of this brain within the sulci. But you see the sulci here are filled with cerebral spinal fluid in this more atrophic brain. So this is a typical, 80-year-old atrophic brain with extensive periventricular white matter flare hyperintensities, meaning high signal in the periventricular regions due to destroyed brain tissue. Okay, I'll just show you a couple other types of stroke, less common, but so you know about them. These are hypertensive hemorrhagic infarcts in the basal ganglia, and this is what's called an SWI sequence, susceptibility weighted imaging, that doesn't have a refocusing pulse such that you'll get magnetic artifact from the blood, from the heme, because it has magnetic properties. And you most commonly see them in the basal ganglia. You can also see them in the periphery along the cortex. This can also be due to another condition called amyloid angiopathy, but I really think they're quite related. I know that because I see them all the time. I see this stuff every day. Now here is this little white spot here in the globus pallidus. That's just calcification. We consider that an incidental finding. What it means is those cells are dead, okay? But it happens chronically, gradually, and slowly, so nobody even notices it. And that would be, bilateral, symmetric, incidental, benign, basal ganglia calcifications. But this is not. This is too big. This right here is an intraparenchymal hemorrhage, meaning a hemorrhage into the brain parenchyma, into the lentiform nucleus region of the deep nuclei of the brain. So this is a big hypertension-related stroke. These are rare. I'll see something like this once every 6 months, okay? This is what everybody worries about, but it's like being worried about getting bitten by a shark. Yeah, it happens and it can be terrible, but it's rare. It's really rare, okay? This is common, and the other stuff I show you is so common I see it all day long every day. Okay, we talked before about the Jack Delatory mechanism of dementia, meaning that he tied off a carotid, then did an autopsy. 2 months later, when the mouse became demented, the brain was shrunken where he tied off the carotid. And he did all kinds of experiments tying off both carotids, the carotids and the verts on one side, etc. Whatever area he tied off, the brain shrunk on that side. And you can get a similar effect, global hypoperfusion, though, by overtreating hypertension, by having atrial fibrillation, underperfusing the brain, congestive heart failure, underperfusing the brain. Hypoxia at night due to lack of breathing. Obstructive sleep apnea can do something similar. If you have severe hypoglycemia, sugar drops too low, you can damage brain cells. Aortic stenosis and regurgitation can lead to underperfusion of the brain. Being put on the pump for open heart surgery during CABG, you can have low blood pressure that can damage the brain. Okay, these are all what I call mouse equivalents. Okay, we went through this, how you need the Goldilocks, golden mean, Aristotelian golden mean. This is just another picture showing something similar. You'll tend to get hemorrhagic infarcts down low in the basal ganglia with hypertension. Up above, you're more likely to get hypoperfusion infarcts, like I was just showing you. Those white spots on the FLAIR axial image. This is just the Wing-Kessel effect of the ascending thoracic aorta, meaning that it normally has a lot of elastic fibers and functions like a second heart. When the heart contracts, that's cardiac systole, it pushes blood into the ascending thoracic aorta, which stretches it outward. Then during diastole is the Greek word for cardiac relaxation, the elastic fibers push inward and then they push blood along the vessels during diastole. So that's how you get more diastolic flow. Chronic hypertension for about 30 years or so, you'll just destroy these fibers, elastic fibers. You can't replace them after adulthood, after 20 years of age. So then you'll be stuck with inability to generate good diastolic flow, and then systolic pressure will have to go up, and that patient will have chronic systolic hypertension that's not fully reversible because you don't have a Wing-Kessel effect anymore. So that's why you want to treat hypertension, the sooner the better. First thing I would do is go on a low-fat vegan diet and minimize dietary salt. Okay. Now, here is Dr. McDougall with Roy Swank, the great multiple sclerosis doctor, and Swank did a lot of experiments to show that high-fat diets cause blood sticking together. So red blood cells have a negative charge on their outer surface called a zeta potential, so they repel each other. All the white blood cells have a zeta potential, negative charge, so they repel each other. All of the arterial lining cells, the endothelium, have a negative charge, so it repels the blood cells. That's what you want. You don't want a clot. In the movies, people die from bleeding. You know, bang, bang, blood on the carpet, excitement, okay, drama. But in real life, people die from clotting, okay? Heart attack, stroke, tissue ischemia leading to tissue damage, leading to cancer, leading to non-function, okay? The higher the LDL cholesterol, the more the red blood cells stick together. Sticking the blood cells together makes the blood thick. You can also call that viscosity, increase in blood viscosity. So the reason you have a blood pressure is to pump blood to your cerebral cortex on the top of your brain against gravity. Normal blood's like pumping water, but if the blood becomes thick like a milkshake, then you're pumping a milkshake. You need higher pressure to get it up there. If you're eating a lot of salt, you're vasoconstricting, narrowing the arteries. So now you got to pump at a higher pressure to get that blood through the constricted arteries to your brain. High-fat diets stick red cells together and cause rouleau formation, meaning stack of coins, thick blood, high viscosity blood, meaning they cause hypertension. And the LDL cholesterol particles do it. That's why they're a risk factor for atherosclerosis. Atherosclerosis just means blood clot. Atherosclerosis is a blood clot. Okay, I did a fellowship in imaging guided surgery at Harvard with the emphasis on vascular disease. I've been writing about this for decades. I'm one of the world experts on atherosclerosis. I've written numerous book chapters on the subject. I've written several books on the subject. I was good friends with Gregory Sloop, who was the greatest cardiovascular pathologist in the world for studying atherosclerosis. He was the pioneer of atherothrombosis theory, meaning that atherosclerosis is just a blood clot. They actually knew that atherosclerosis was just a blood clot back in the 1850s, Rokitansky, Virchow pathologists, because they could look at it under a microscope. But then there was all this confusion caused by the Ansel Keys and the statin medicines for cholesterol, okay? So I'm just taking it to a higher level of pathophysiology so you can understand it. So here are the red blood cells traveling through a capillary. Typical red blood cell is about 7 microns in diameter. Typical capillary is about 5 microns. So they have to fold back upon themselves to get through the capillary. If you stick them all together because of these bridging molecules, which could be LDL cholesterol, triglycerides in the blood, it can be other things that'll stick them together, IgM antibodies. These are some of the things that'll do that. Okay, chylomicrons will do that. Okay, in the movie Game Changers, you can see the test tubes. When a person eats the high-fat meal, the plasma becomes opaque of the collected blood in a test tube. Okay. Here's the work from the Roy Swank experiment. And McDougall has a video of this on his YouTube channel. It's called Blood Sludge, Blood Flow Before and After Eating a Fatty Meal. The red blood cells will stick together. This is a paper by Swank. They'll clump together. So again, you're pumping thick blood. Pressure has to go up. And when all the red cells are stuck together, then you get less oxygen delivered to the tissues. Here's Dr. Swank's paper, Intravascular Aggregation Association with Elementary Lipemia, High Blood Fat. So the chylomicrons stuck the red blood cells together. Here's a paper showing that triglyceride has a similar effect. It's associated with increased rouleau formation. Rouleau formation means stack of coins in French. The rate of rouleau formation was increased with an increase in triglyceride concentration. Okay, the enhanced red blood cell aggregation caused less oxygen released to the tissue from the RBCs. In conclusion, high triglyceride in the plasma causes prevents homogeneous tissue oxygenation, lowers oxygen delivery to your brain cells. Okay, here's a paper by Gregory Sloop showing LDL lipoproteins, LDL cholesterol, increasing blood viscosity, which is going to lower oxygen delivery to the tissues. Here's the work of Peter Kuo, and later on Meyer Friedman and Ray Rosenman did similar work to show that when you eat the high-fat meal, you get less oxygen delivered to the tissues. And the fat accumulates in the blood. They've done it with people. Peter Kuo was a cardiologist. They would get cardiac anginal attacks at peak lipemia. He was checking their blood lipids every 30 minutes. And what Meyer Friedman and Ray Rosenman show, Kuo was working especially with sat fat, but they did it later with unsat fat, omega-6 oils, that it was even worse, the blood sludge rouleau formation effect, okay? So that's why when you hear people telling you that omega-3s are okay, you know they're BS artists, okay? This was figured out a long time ago in the 1950s and 60s. Here's the article by Ray Rosenman and Meyer Friedman. And they were observing the little tiny arteries in the eye, on the eyeball, with a 80 magnification microscope. And this is 4 hours after feeding them the high-fat meal. This particular study was a lot of sat fat because it's coming from bacon and milk and butter and cream. It reduced the oxygen delivery by 20% to the tissues. That's a lot. I've also shown in previous lectures the work, of Douglas Kellogg, Atherese Pretoris, that you get increased clotting in the blood from leaky gut due to bacterial endotoxins, LPS from gram-negative bacteria, LTA from gram-positive bacteria. LPS means lipopolysaccharide. LTA means lipoteichoic acid. You'll also get, this is called an amyloid transformation of the blood clotting protein, fibrinogen. You'll get that from infections, and you'll also get it from iron overload if there's increased free iron in the blood. They induce a change in the shape of fibrinogen, the blood clotting protein, from being alpha helix, like a cylinder, like a slinky, so to speak, to becoming flat. So it goes from cylindrical to flat, beta-pleated sheet, this is called, for secondary protein structure. And then it'll start to bind to itself, increasing its molecular weight, and then precipitate out of solution. So these are called amyloid microclots, sometimes also called fibrinolytic clots. This is also showing the mechanism by which iron can cause all these problems, because it's a transitional metal with a variable valence, and it can undergo what's called ferrous redox cycling between Fe2 plus Fe3 plus Fe2 plus Fe3 plus, and in so doing give off electrons that will cause free radicals, unpaired electrons in the outer orbital of molecules like hydroxyl radical, and that'll damage the blood clotting protein fibrinogen, making it undergo that amyloid transformation I just spoke about a moment ago. Another thing to know about a brain stroke is in the center you'll have the core brain, the black circle here, that's dead brain. But around the periphery of it you'll have penumbra, which like in Greek means twilight. And this is brain which is salvageable. It might live or it might die. Okay, so that's a good way to think of brain tissue, and why you always want to have good health habits, good blood flow habits, so you don't damage your brain tissue. Almost done here, a couple more slides. This is just showing normal red blood cells going through a capillary in the brain. The blue circles are the oxygen given off. The yellow is the normal capillary basement membrane. The green is the vascular smooth muscle, like the pericytes in the brain. When you've got a lot of diabetes, you get chronic thickening of the capillary basement membrane. You get hypertrophy of the vascular smooth muscle. Now the oxygen has to travel increased distance to get to the neuron, so I showed fewer blue circles going to the neuron. So you get a relative chronic baseline hypoxia of the brain cells. And then when you superimpose other things on top of that, like the amyloid clotting, the high-fat meal, then this neuron is further deprived of oxygen, and the neuron might die because of that. Okay, here's just showing a capillary network, and it's like a lattice. And so if you just plug up one little side branch of it, not a big deal. But if you plug up the main trunk, or you plug up a bunch of these side branches due to high-fat diet particles, due to plastic microparticles, or other cause, amyloid clots, you can significantly drop the oxygen delivered to the tissue. Here's showing an acute stroke, like we showed earlier, of a large vessel occlusion. And then this would be the core infarct, completely dead brain. This would be the penumbra, potentially salvageable. It's getting some collateral blood flow, for example, through the anterior cerebral artery branches coming up from above. Okay. All right, we just showed this before. This would be, normal brain over here, and these are all the white spots of small strokes. This is just alluding to when you've got leaky gut, you'll also have leaky blood-brain barrier, because the same good stuff, the short-chain fatty acids, butyrate, that makes the tight junctions, that helps the enterocyte lining of the gut to make tight junctions, also goes up to the brain endothelium, blood-brain barrier, and it's used to make tight junctions up there. So if you got leaky gut, you probably have leaky blood-brain barrier, which is not good, because that means toxic chemicals like LPS and LTA can get into the brain and contact the brain parenchyma, and that will elicit an immune system response by like the microglia, the brain's immune cells, that can cause collateral damage to adjacent neurons. Okay, here is just, kind of showing the same thing, how you need butyrate to make your blood-brain barrier. We're not going to get into that too much. One normal variation I want to show you is just that some people have this. I'm going to ballpark guess it's about 7%, whereby normally in an adult brain, the carotid arteries are big, and they make a big MCA and a big ACA, anterior cerebral artery, middle cerebral artery, but they have a very small communicating artery, meaning there's not much communication between the anterior circulation, the carotids, and the vertebrals. However, some people have a persistent fetal anatomy, like persistent embryologic anatomy, where they'll have big PCOMs. When a person has this normal variant, they'll get underdevelopment of the basilar and the vertebral arteries. We call it vertebral basilar hypoplasia. These patients have increased risk of a brainstem stroke if they eat an atherogenic diet. So, because the basilar artery runs right along in the basal cistern, right along the front of the pons, the brainstem, if it is small in diameter, a relatively small amount of atherosclerosis can plug up parts of it that will then plug up the pontine perforating arteries. So what I'm basically saying here is you don't know if you have this. Any one of us could have this, but you don't know unless you check an MRI or a CT scan. So the smart thing is to just assume that you have it, a slightly increased risk of brainstem and posterior fossa cerebellar infarct. Okay. Okay, here's just the paper to go with it. All right. Now let me just show you. Okay, here's what these posterior fossa infarcts look like. Pop, 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 pop. Pontine infarct, left paramedian pontine infarct, left cerebellar hemisphere infarct, right cerebellar hemisphere infarct, okay, etc. Okay, here's another weird thing. Some people have normal variant anatomy where the cerebellar tonsils project down below the foramen magnum. The basion is the front of it, the opistheon is the back of it, so we call it the BO line, basion-opistheon line. And they can also have normal variant arteries, normal variant picas, posterior inferior cerebellar arteries that drop below there, which can be damaged if you do crazy things like yoga and put your foot behind your head. It's a stupid thing to do. You can damage this artery. Like here's a normal variant pica that drops down into the foramen magnum, and that can be injured with crazy yoga stuff. So I'll just show you what that's like. Oh, and this is funny. This is like, he's some type of pastor, theologian. This guy's a priest. And they're talking about how yoga is possessed and yoga is demonic. I thought that was kind of funny. And I do think a lot of that yoga stuff is crazy. And I've heard all these people having all kinds of neurologic problems from doing meditation. I don't know how common it is, but there's a bunch of videos on that. I previously linked to it. I thought it was funny. All right, so anyways, like I said, I'm not too impressed by standing in front of a wall saying Om, okay? I had a picture of a lady putting her foot behind her head. That's what I wanted to show you because I knew a doctor who had a personal trainer, and the personal trainer was doing yoga. He put his foot behind his head. He had a stroke. All right, so transient visual loss, TVL. What could cause it? What do you do? Number one, it could just be because you're stressed out and distracted, okay, and you're sleep deprived. Number two, it could be rebound hypoglycemia because you ate something really sweet or caffeine and you got transient hypoglycemia, low blood glucose, and it gave you symptoms of this. Sometimes it would be associated with visual symptoms like these shimmering lights called scintillating scotomata. If you're heavily fasted, you could have a depleted liver glycogen, less ability to compensate for a rebound hypoglycemia effect. If you exercise a tremendous amount and then you combine all these things simultaneously, prolonged exercise, depleted liver glycogen, and caffeine, that could make the situation worse. There is something called ocular migraines, which can present exactly the same as rebound hypoglycemia. If you think you have either one of these, and I think I've had episodes of both of these in the past, what I do is I just guzzle down 32 ounces of beet juice, chase it with 12 ounces of water, and it usually resolves in about 5-10 minutes, sometimes 15 minutes. You can have a vertebral artery dissection like I talked about, putting your foot behind your neck or having some trauma to your neck. I wonder if vitamin B12 deficiency might be able to cause something like this due to optic nerve atrophy. I don't know for sure if that's true or not, but I would think about that. The whole B12 thing is complicated. I used to take more. Now I take a tiny amount once every about 2-3 months. I'm not sure I need to take it at all. I just don't have the time. It would take 2 months of dedicated reading to figure out what's real and what's not real in the B12 literature. It's so full of contradictions. So much of it's bogus from big pharma companies. We talked about this in previous videos. Okay, like if I go upstairs, and I often run upstairs, and I often do it carrying a backpack, 20-25 pounds of books in there. So what I'll do is I used to carry the backpack on my shoulder, but I don't do that anymore because it can injure your vertebral artery, and I one time felt a transient decreased visual symptoms when I went up. So now I just carry it in front of me. I never put it on my shoulder when I'm going upstairs. There's other things relatively uncommon, giant cell arteritis associated with jaw claudication. I've seen like one case of that in the last 30 years, so it's pretty rare. Idiopathic intracranial hypertension with papilledema, that's like a fat female, somebody, a female 50 or more pounds overweight. and she'll have more symptoms typically. She can go into the emergency room for that. Due to severe Valsalva, somebody squatting a heavy weight, maybe. Pain with optic neuritis associated with multiple sclerosis, pretty rare, but that can happen. But usually you're dealing with an MS patient. Visual loss related to glaucoma. A fall with trauma to the occipital lobes in the back of the head. Fall and you hit the back of your head. Let's see. You could have posterior reversible encephalopathy syndrome, pretty rare, with severe hypertension, usually systolics like around 200. Cortical blindness means damage to the brain, cerebral cortex in your occipital lobe or your parietal lobe. So the occipital lobe is your visual center. Parietal lobe is part of the processing brain tissue for making sense of what you see. So this would be cortical blindness when you see something but you can't interpret it. So there's a problem with the interpretive apparatus. You can also damage your occipital lobes or your parietal lobe due to head trauma if you fall and hit your head. Let's see. And again, if you got any of this migraine-like stuff, hypoglycemia-like stuff, I like to drink 32 ounces of Biota beet juice chased with 12 ounces of water, and it goes away real fast. If you go to the emergency room, if you think you're having a stroke, then you go to the emergency room. Acute stroke, less than 24 hours, they'll run a stroke protocol. They'll get a non-contrast head, CT, CAT scan to make sure you're not having intracranial bleed. They'll do an emergency stat, CT angiogram, we usually call them CTA, to check the arteries in the neck and intracranial to see if there's an occlusion. They're almost always negative. I see a positive one maybe once out of every 200. But just in case, you could catch a big vessel. Usually you'd have a bigger stroke than just a little visual loss. You'd have this giant unilateral hemiplegia. And this is the one where if it's positive in the acute setting, they could potentially go in there with a catheter and pull out that clot. But again, that's a rare type of stroke to have that. But it can happen. It does happen. Then the patient, if this is all negative, which it usually is, they'll send the patient for an MRI. The main thing they want to check is DWI, diffusion-weighted imaging, which is the earliest that becomes positive and the most sensitive to detect an acute stroke. In which case, neurology will then decide what to do with you to try to prevent a repeat event. They'll talk to you about atherosclerosis risk factors. Usually if the patient has high cholesterol, put them on a statin. If they're hypertensive, antihypertensive medications, diabetes medication, some type of clot prevention like platelet inhibitor like aspirin, but potentially, depending on the context, even Plavix or something stronger like that. And that's pretty much the big overview on transient visual loss. So I know that was kind of a big lecture, but here it is. So you got the information if anybody wants it. I hope you found that helpful.